My study is about how family income inequalities and trajectories are linked to the risk of self-harm in young people. And this is a collaboration between the University of Manchester and Aarhus University in Denmark. And we are funded by the European Research Council. Okay, so first of all, we already know that poverty and socio-economic disadvantage are linked to poor outcomes in children and young people. And this includes poor child development and the increased risk for psychological distress and self-harm. We're interested in self-harm because it is one of the main risk factors for subsequent suicide. And especially amongst young people, it has been a growing public health concern in recent years. However, what is unknown is that how the risk of self-harm can be modified by the changes in family income levels over the childhood period is unclear. And so the aim of our study is to investigate the link between parental income trajectories, and this is what I meant by the, which is actually meant the changes in parental income levels during the childhood period and the subsequent risk for self-harm. And we measured parental income at 4 time points, and this is in the year of the childbirth and at age 5, 10, and 15. We also assessed how the amount of time spent in financial disadvantage versus more affluent conditions during childhood modifies the risk. Although the bulk of my talk is going to be on self-harm, we actually also examine violent offending as a second outcome. And this is because a lot of research has shown that, I don't know why it keeps on jumping. Sorry about that. Because a lot of research has shown that self-harm and violent offending, they share some similar risk factors. And so you can conceptualize the two outcomes as self-directed versus interpersonal violence, or internally directed versus externally directed violence. Okay, so we actually used data from Denmark to conduct our study. And this is because in Denmark, they have a very good comprehensive system that everybody who are born in the country or who entered the country as an immigrant is registered in this civil registration system. And so basically, registration is compulsory, so this covers the whole of the Danish population. And it records information such as the person's gender, the date of birth, date of death. But then most importantly, everybody in this system has got a unique identity number. And so basically using this number, it follows you through from birth to death, and you have to use it for schools, for employment, for hospitals. And you can link each person to their parents and also to their siblings as well. And so for the purpose of our study, we link this information to the Income Statistics Register to obtain information on parental income during childhood, and also to the Psychiatric Central and the National Patient Registers to obtain information on self-harm episodes which have been treated in hospital settings. And we also linked it to the National Crime Register to obtain information on violent crime convictions. Okay, as I said before, parental income was measured at 4 time points at birth, age 5, 10, and 15. We divide the parental incomes into quintiles, which means we divide them into fifths. So quintile 1 represents the lowest income families. And quintile 5, these are the highest income, the most affluent families. Okay, so first of all, we look at the relative risk of self-harm according to the parental income measured in the year of birth. And I will explain what I meant relative risk in a minute. So, so here I'm plotting the relative risk against the parental income level at birth. So quintile 1 is the lowest income families, and quintile 5 the highest. So by relative risk, what I meant was that the risk of self-harm for quintiles 1, 2, 3, and 4 were measured using against this reference category of the most affluent families. So here you can see that basically the lower the parental income level, so as you go from this end to this end, the higher the risk of the subsequent self-harm. And so people who were born in low income families have got about like a 3.5 times higher risk compared to those who were born in the most affluent families. Okay, so this is the pattern for parental income measured in the year of birth. And for income measured at age 5, 10, and 15, we saw very similar risk patterns, same as here. So I'm not going to show you that at the moment. Okay, next we look at the relative risk of self-harm according to the amount of time spent in financial disadvantage versus more affluent conditions during childhood. Okay, so here I'm plotting the relative risk against what we call like a parental income scale. And basically, at the lower end of this scale, this represents the people who are continuously the least affluent during childhood. And at the other end, we have the people who were born in the most affluent families, and they remain in the most affluent families during childhood. And this is the point where we use for the risk estimation, relative risk estimation. So here you can see that as you go from this more advantaged end to this more disadvantaged end, you can see this is related to an increase in, associated with an increase in subsequent risk of self-harm. But then you can also see that this increase in risk is not actually linear. So the people who are at this more disadvantaged end, they actually have got a disproportionately higher risk compared to those in the middle or at the other end. Okay, next we look at the relative risk of self-harm according to the changes in income between birth and age 15. So here we are looking at differences between the parental income differences between the two time points. Okay, so first of all, we look at the people who were born in the most affluent. These are the richest family. So I'm plotting the risk again according to the parental income quintiles at age 15. So this reference category are the people who were born in quintile 5, and they also remain in quintile 5 at age 15. And at the other end, we have the people who were born in quintile 5, but then by the time they reach age 15, their parental income has dropped from the highest to the lowest income quintile. And so here you can see that as the parental level, the parental income level dropped from one end to the other end, you can see that this is associated with an increase in risk of self-harm. And you can also see that basically being downwardly mobile economically is associated with an increase in risk of self-harm. Okay, so how does the risk patterns compare to those who are born in the lowest income quintile? So the orange bars are the ones that we saw in the previous slides. And the red bars here are the ones they're related to they're associated with those who are born in the lowest income families. And we still have the same reference category here. So these are the people who are born and remain in quintile 5 between birth and age 15. So first of all, you can see that for those who are born in the lowest income families, generally speaking, these people have got a higher risk of self-harm compared to those who are born in the most affluent families. And especially for those who are born in quintile 1 and remain in quintile 1 as well, these people have got the highest risk. But then just as being downwardly mobile is associated with an increase in risk of self-harm, now you can also see that being upwardly mobile between the two ages associated with a decrease in a lower risk of self-harm. And I just want to point out that, so for example, if you're born in quintile 1, but then if your parental income could increase from 1 to 5 between birth and age 15, these people here, this sort of, so this group here, this is the most upwardly mobile group. These people actually have got a lower risk of self-harm compared to the most downwardly mobile group. So these are people who go from quintile 5 to quintile 1. Okay, so how about for violent offending? So for violent offending, we saw a very similar risk patterns compared to those as for self-harm. But we are seeing even stronger associations here. So I'm just going to show you one slide, just as an example. So here, this is the slides that we saw earlier for self-harm. So here I'm presenting the risk of self-harm and violent offending according to the amount of time spent in a financial advantage versus more affluent conditions. And so here, the blue lines here is for self-harm, which we saw earlier. And then for the violent offending, so you can see the red lines here. So you can see that there's actually stronger associations for violent offending. And this is especially for those who are continuously the least affluent during childhood. Okay, so how do we interpret these findings? Even though we're only looking at the parental income, but basically parental income is not only an indicator for financial or material resources, it actually captures a range of other influences on the child development, such as housing, neighborhood, education, and social participation as well. And we also know that family adversities are interrelated. So children from poor families are more likely to be exposed to other hardships as well. So basically, a parental income is not just about money or the material standard of living, but it's actually a marker for a range of family physical and psychosocial environment. So our study has shown that income inequality during childhood, and not only about the low income, is associated with the subsequent risk of both self-harm and violent offending. The longer a child lives in poor circumstances, the higher the risk of both outcomes, and vice versa for the amount of time spent in more affluent conditions. And for any parental income level above, being upwardly mobile or economically is associated with a lower risk of both outcomes compared with being downwardly mobile. And so basically, our study has added to the evidence that if we can tackle the underlying causes of inequality and to enable economic mobility, and this could potentially reduce the risk of suicidal behaviors and interpersonal violence in the longer term. And this is our paper, which was published in the October issue of the Lancet Public Health. Thank you very much for listening.